Hello to everyone. I would like to thank the MDS Foundation and the Scientific Board for inviting me to discuss about the relevance of germline predisposition in patients with MDS. I have no conflicts of interest to disclose. So I'm first focusing on the case of a 65-year-old man referred to our institution for an incidental finding of a mild to moderate pancytopenia. And after excluding common causes through peripheral blood tests, the patients underwent a bone marrow biopsy that showed a cellularity of 10% and 2% CD34 positive cells. Conventional cytogenetic analysis was normal, and the standard myeloid somatic mutation analysis failed to detect pathogenic mutations. So the conclusion of the diagnostic workup at this stage was of non-severe aplastic anemia. 15 months after diagnosis, a worsening of cytopenia was noticed, and a bone marrow examination was performed, showing a 10% CD34 positive cells, consistent with a progression into MDS with excess blasts. The patient was enrolled in a program for germline predisposition and extended somatic mutation profiling, which show a germline DDX41 mutation associated with the somatic DDX41 mutations involving the wild-type allele. A search for a stem cell donor was then started, and a treatment with azacitidine was introduced, with gaining of a marrow complete remission. This case highlights the relevance of genetic predisposition to MDS, which has been formally included into 2017 revision of the WHO classification of myeloid neoplasm. And according to the original proposal, predisposing conditions were subdivided according to the absence or presence of pre-existing hematologic phenotype and/or organ dysfunction. However, several questions remain open, including the true prevalence in adult patients with suspected MDS, the clinical implications, the selection of the most appropriate candidates for screening, as well as methodological issues, including the choice of control tissue and interpretation of variants. The available studies on the frequency of germline predisposition have been mainly focused on pediatric population, mainly selected based on clinical suspicion or a positive family history, while systematic studies on the frequency of germline predisposition in adults with MDS are not available. In a recent study on young adults with apparently sporadic MDS-AML or aplastic anemia, a 15 to 20% prevalence was reported. While in a large unselected cohort of MDS patients undergoing allogeneic stem cell transplantation enrolled in the International Blood and Marrow Transplant Research Repository, a prevalence of 11% of GATA2 deficiency and 2% of compound heterozygous mutations in the Schwachman-Diamond syndrome-associated SBDS gene. Thus, the emerging evidence, though not exhaustive, is consistently pointing toward a high prevalence of germline predisposition in unselected cohort of adult patients. Additional international efforts are warranted to clarify, based on adequate sample size, these relevant issues. And I invite you to attend a presentation of Hideki Makishima on a large cooperative study on DDX41 myeloid neoplasms coordinated by Sei Shogawa. The study gathered more than 6,000 patients with myeloid neoplasms, and we provide firm answers to all the open questions on these conditions. Overall, DDX41 mutations were detected in 3 to 4% of patients with MDS-AML. About 50% of the patients with germline mutation progressed to myeloid neoplasm through the acquisition of a second hit in the gene. But notably, a fraction of patients harbored somatic DDX41 mutation alone, without an underlying germline mutation, thus having a purely somatic disorder. The clinical implication of germline predisposition, supporting a screening either on a selected subset or on a systematic basis, are relevant. including a correct interpretation of the hematologic phenotype, the constraint of pathways of somatic progression, the effect on clinical outcomes, including survival and risk of the disease progression, the effect on response to the available treatment modalities, the selection of hematopoietic stem cell sibling donor, as well as appropriate genetic counseling for patients and their relatives. The interpretation of hematologic phenotype in patients with an underlying germline disorder is challenging. We recently undertook a study on germline screening, including 402 consecutive patients with cytopenia and age-adjusted bone marrow hypocellularity. Overall, we found 12% of the cohort with a germline profile causative of an inherited disorder predisposing to myeloid neoplasm. 60% of these patients receive a diagnosis of myeloid neoplasms. But notably, a fraction of these patients did not show somatic genetic lesions, suggesting that conventional morphological criteria might be inadequate in the context of germline disorder to correctly diagnose hematologic phenotype and capture a progression into a somatic myeloid neoplasm-driven disorder. Germline mutations are also critical to understand somatic clonal dynamics and to effectively intercept clonal evolutionary trajectories under the selective pressure of germline variants. The detection of a monosomy 7 may subtend a MD9-like mutation, which may promote a revertant mosaicism, characterized by the loss of the chromosome 7 carrying the mutant allele, and the expansion of a myelodysplastic clone with monosomy 7. As mentioned, germline DDX41 mutations often progress to myeloid neoplasm through the acquisition of a second somatic hit involving the wild-type allele, which is often missed by somatic myeloid gene panels usually adopted in current clinical practice. Then the presence of an underlying germline predisposition may have a significant effect on clinical outcomes. Emerging data are suggesting that MDS AML patients with germline DDX41 mutation tend to have a favorable outcome and a high response rate to disease-modifying treatments. While in the mentioned study of the IBMTR registry, biallelic SBDS mutations as well as TERT mutations were associated with inferior post-transplant outcome, prompting to appropriate transplantation strategies, including informed donor selection, as well as ad hoc conditioning regimens. Several variables have been suggested as potentially useful to identify patients with a higher likelihood of an underlying germline disorder, and to inform an effective genetic screening, including age, hypocellular bone marrow, extrahematological signs, family history of hematologic and or non-hematologic cancer, or a personal history of multiple tumors. Age is the most intuitive variable. However, although on average patients with germline mutations tend to be younger, selected mutated genes are characterized by a late onset, suggesting that germline predisposition is preferential but not exclusive of younger patients. Other clinical variables are also potentially informative. However, some conditions are not associated to a pre-existing disorder or organ dysfunction, eluding clinically driven investigations. These include, for instance, DDX41 mutation. Preliminary data are suggesting that the germline mutation might result in mild cytopenia preceding somatic evolution. However, in most cases, slipping through a clinical detection. Other conditions are in principle characterized by distinctive hematologic or extrahematologic features. However, a late clinical onset in adulthood subtends a selection of disorders and variants with incomplete penetrance and or mild clinical expressivity, resulting in many cases in a very mild or even absent clinical phenotype, again eluding a clinically primed suspicion and investigation. Finally, The interpretation of germline variants in the clinical settings is complex. Consensus-based standards and recommendations have been developed to provide guidance by integrating a spectrum of information sources. However, this is often resulting in a high rate of variance of uncertain significance. In fact, one of the key factors required for reclassification is the direct evidence of a functional relevance of variance. And the previously mentioned study by Rayleigh and colleagues on TERT variants in MDS patients, including in the IBMTR database, provides a paradigm of the approach that has to be adopted to generate the evidence required for interpretation of germline variants. In fact, after identifying TERT rare mutations, the author undertook the huge effort of cloning each single variant and quantifying its impact on the telomere elongation in vitro assays, hence generating the evidence required to apply the analysis of these variants in the clinical setting, and offering a tangible example of the long way required to build the evidence for clinical implementation of germline testing in myeloid malignancies. With this aim in mind, collaborative efforts and international networkings are warranted. The best example is ClinGen, a large collaborative effort funded by the National Institutes of Health, with the aim to building a central resource that defines the clinical relevance of genes and variants for use in precision medicine and research. And the myeloid malignancy variant curation expert panel has been created collaboratively between ASH and ClinGen, chaired by Lucy Godley and David Wu, to perform gene and disease-specific modifications for inherited myeloid malignancies, including the identification of functional domains, mutational hotspots, and functional assays. So, in conclusion, emerging evidence is suggesting that germline predisposition has a prevalence higher than expected in adult patients with apparently sporadic MDS. Incomplete penetrance and mild clinical expressivity of many disorders complicate the identification of patients candidate to screening for germline variants. Germline's predisposition has major clinical implication in adult patients with MDS, affecting hematologic and extrahematologic phenotype, response to treatment, and clinical outcome. Germline predispositions appears to be relevant to clinical decision-making in patients with MDS AML and should be taken into account in diagnosis, treatment, and transplantation strategies. Classification of variants remain critical, and international collaborative efforts are required to develop and implement standards to support clinical annotation and interpretation of genes and variants. I stop here, and I would like to thank my group in Pavia first, all the people I have been having the privilege to collaborate with within our international networks, including the International Working Group for Prognosis in MDS, the European MDS Registry, MDS, and the MDS Right Consortium, as well as the MDS Foundation and the Italian Association for Cancer Research, AIRC, for their invaluable support to research in MDS. Thank you for your attention.